So I'm going to talk about trainer 4 monitoring, which is regularly done very commonly, but there are some issues sometimes, and we just want to make sure to avoid anything. Okay. Yes. So the learning objective for the today presentation is to review the anatomy and physiology of the related to trainer 4 setup. Also review the trainer 4 data interpretation. And I am alert to the surgical team when we alert the surgical team and what is the effect of the trained data on that. So if you're not monitoring or have and the last one is the learning about the advantages of the accurately monitoring trainer 4 as well as potential pitfalls of errors. So going from the history, in 1970, Ali et al. He published the first paper and developed the technique for trainer 4 monitoring. The trainer 4 pattern was an attempt to provide a clinical tool to assess the neuromuscular block in the anesthetized patient. The principle was to produce a pattern of stimulation that did not require the comparison of evoked responses to the control baseline. So normally when we do any data, so you have to compare with the baseline. So the purpose of developing trainer 4 is to get a data about the patient muscle relaxation when patient is under anesthesia and without comparing with the previous trace. So it's a one-time stimulation and it gives information about what is the status at the time. So if you are getting a bad echo, I'm going to try to call in from my number. Give me a minute.
Please enter your access code followed by the pound or hash sign. Please enter your access code followed by the pound or hash sign.
Hello? I think it's better now. I'm sorry for that echo. Okay. So going for the history, just brief history, the pattern of involved in stimulation of the ulnar nerve. So the initial pattern was to stimulate the ulnar nerve with 4 twitches and with supramaximal stimulation and the frequency of 2 Hertz for 2 seconds. That's 2 Hertz for 2 seconds. So 4 stimuli with every stimuli half second apart. The trainer 4 was then repeated every 10 seconds at a frequency of 0.1 Hertz, as well as enabling the observer to compare T1, which is the first twitch, to T0, which is control twitch, and also comparing the T4, which is the last twitch, to first twitch. So this is just, I'm going to go into more detail. So all the patients who receive any neuromuscular blocking agent should be monitored for neuromuscular function during the surgeries. Anatomy of the neuromuscular junction. So it's a junction between the terminal branch of a nerve fiber or lower motor neurons and the muscle. And the terminal fibers, the neurofiber can be of different sizes and they have different diameters. And so the nerve fiber, the terminal fiber, which make a synapse with the muscle, is known as presynaptic terminal. And then you have a cleft, which is the gap between the nerve ending and the muscle fiber. And then we have receptors at the motor end plate. The motor end plate is the area where the nerve fiber is making a synapse. and the neurotransmitters are released by the N terminal, and they are taken up by the receptors. And those receptors, they are controlled by sodium potassium pump, and also to run them, they are calcium gated, so need calcium. So the reason I'm mentioning that is having the information about the anatomy is very important, because all these factors, they are factors in running the trainer 4 or running a twitch, or if you do voluntary muscle control, or or evoked response. So you have calcium involved, you have potassium involved, you have sodium involved, acetylcholine released. So all these factors. So if there's any imbalance in the blood, so if there's a hypokalemia, hyponatremia, or hypocalcemia, so any of these factors, that will affect your neuromuscular junction. So again, the axon branch, the terminal, it has connection and with the muscle fiber, and the one muscle fiber is surrounded by a membrane, and inside you have multiple myofibril, and all those myofibril, they have uh, synapses. So if you just look at a overview, so we are doing a posterior tibial nerve, we put the electrodes. When we are doing SSCP, so we put the distal electrode as anode and proximal as cathode, which is, so that's why we reverse the polarities, because we are stimulating the same pair and we are recording from the foot muscle. So going to the physiology, so the neurotransmitter which is released by the nerve terminal is called acetylcholine. It is stored in small bubbles which are called vesicles and they are, when you stimulate or cause any evoked response, they reach the end of the membrane and they are released in the cleft or the junction, and they are attached. They act on the muscle fiber and cause contraction. So the acetylcholine, they are synthesized for choline acetate. So if there's any imbalance on choline or if there's imbalance in acetate, that will affect your neuromuscular junction also. So they are stored in vesicles at the motor end plate, and they're metabolized by choline esterase within milliseconds. So if there's a patient has a deficiency of choline esterase, that will affect your signal also. So there are multiple type of receptors on the muscle fiber, and they consist of 5 glycoprotein subunits to form an ion channel. There are 2 alpha, 1 beta, 1 delta, and 1 gamma. Acetylcholine binds to the 2 alpha subunits, and there are 1 to 2 million receptors across the membrane, and only 1 alpha subunit is enough to block the non-depolarizing muscle relaxant. So now there are 2 different type of muscle relaxant we see in the operating room. One is called depolarizers and the other are called non-depolarizers. So the only one in depolarizer we see is succinylcholine, and there's a long list of non-depolarizers: curare, pancuranium, vecuranium, rocuranium, etricuranium, cisplaticuranium, mevacuranium. So all these are non-depolarizing agents, and some of them are short-acting, some of them medium-acting, and some of them are long-acting. So that the succinylcholine is the ultra short-acting, and it lasts for about few minutes. But the other one, they can run from 20 minutes to 90 minutes. So the depolarizer succinylcholine is 2 acetylcholine molecules. They bind together and they act like acetylcholine at postsynaptic receptors. So normally the acetylcholine is released and it binds to the muscle receptor and cause contraction. The succinylcholine, there are 2 acetylcholine molecules and they act like acetylcholine and they bind with the receptor. When they bind the receptor, they cause depolarization, so we cannot stimulate anymore. And the typical characteristic, there are 2 types of blocks. One is called phase 1 block and the other one is called phase 2 block. So the phase 1 block, it decreases the single twitch. So every time you stimulate, it decreases the amplitude of the twitch. There's no fade. So if you're stimulating multiple single twitches, there's no fade with using a depolarizer. So you can look at the train of 4 or a response, and you can tell if the patient has a using a depolarizer, muscle relaxant, or non-depolarizer, because the depolarizer will have no fade compared to non-depolarizer will have a fade. The train of 4 ratio is, will be greater than 0.7 if there's a present, and the potentiation of an anticholinesterase drug can also be present. Succinylcholine also causes fasciculation, and if we move to the phase 2 block, it resembles the non-depolarizer blockade. And the non-depolarizer blockade is act on at least one alpha subunit to block conduction. So the function of non-depolarizer is to block the conduction. Compared to depolarizer, it causes contraction or depolarization wave before the release of acetylcholine. So there's no receptor to uptake that acetylcholine. The non-depolarizer, vecuronium, rocuronium, they are all competitive antagonists. So they're competing with the acetylcholine to bind to the receptors, and they decrease the twitch response to single stimulus. So every time you stimulate, and if you have a used non-depolarizing agent, it will decrease the single stimulation response. It produces a fade. So there will be always a fade when you're using the non-depolarizer. The ratio of will be less than 0.7. It also causes, we can do the post-tetanic facilitation. Potentiation of other non-depolarizers, so if you're using 2, it increases the effect of that. It antagonism by acetylcholine drugs. So anticholinesterase drugs, so they can do antagonize those muscle. So if the muscle relaxant is given, it is given intravenously. When the drug is intravenously, it goes to the heart and it pumps to the whole body. So, and the heart pumps usually 70 beats per minute, which is about 1.1 beat per second. So there's a 5 to 6 liter of blood in the body. So every minute there like 5-6 liter blood is pumped to the whole body. So all the muscles in the body which have higher blood supply, have a better supply, will be paralyzed before the second one. So the face has very small muscles, and the ratio of the blood flow, which is the facial artery, so the ratio of the blood flow to the muscles is very high. So the drug reaches to the facial muscle very quickly. So the face is paralyzed. So you can have zero twitch in the face without any with 4 twitches in hand and leg. So the hand are paralyzed second, upper extremity, and the lower extremity is the last one to be paralyzed. So when we stopped giving the drugs, the face is reversed first, because same as blood supply, the venous drainage, the veins, they drain the blood very quickly compared to the hand, and leg has a big femoral artery or femoral vein, and the blood flow coming out of the muscle is very, very slow. So face muscle are the first one to get paralyzed by muscle relaxant, and the first one to get 4 twitches back. And the feet muscle are the last one to get paralyzed, and the last one to get 4 twitches back. So that's why if we are monitoring foot muscle MEP or EMG, it's always recommended to use train of 4 on foot. Never do on hand or face if you are doing a foot muscles EMG. So why we give muscle relaxants? So if they are so affecting our signal, why not just avoid? There's a need of muscle relaxant during surgical procedure, and number one need is because of adequate intubation. So the patient trachea is relaxed. If we don't give muscle relaxant, the trachea contraction and can damage the trachea or cause laceration. So by giving muscle relaxant, the intubation is easier. It also give an adequate surgical exposure and also improve mechanical ventilation. So why we monitor neuromuscular junction? Due to the variable responses from muscle relaxant. So we don't know what will be the effect and what will be the recovery time. So every drug has a different effect, and every patient is different. Every patient have different calcium, potassium levels. So that's why in order to get a response or get the information, we need to monitor neuromuscular junction because of, and so there is no detectable block from 75 to 85%. So if you lose one twitch, you lose 75 to 80% of muscle and there's no way to monitor with any way. So that's why it gives us a benefit to know how it's going, the patient is doing. So in order to achieve a surgical relaxation, we need more than 90% muscles in the body blocked. So 90% muscle relaxant is required to have a surgical relaxation. For intubation, we need 95% muscle relaxation. And in order to have total flaccidity, paralysis, we need 99% muscle relaxation. There are different type of muscle neuromuscular stimulator in the market. The three one which are there are only three that are used is one is called single twitch, the second one is tetanic stimulation, and the third one is strain force stimulation. The single twitch is a single twitch, as name says, so it's a monophasic square pulse. The duration of the pulse is 0.5 millisecond. These are the least precise, and they need baseline. With a single twitch, you need to have a baseline before you give muscle action, and you compare each twitch with the baseline twitch. So the first indication is 75 to 80% block, and twitch. If the twitch disappears, that means patient has a 90 to 95% block. So single stimuli are applied to peripheral motor nerve, and the rate of stimulation is 0.1 to 1 hertz. So you're doing single stimulation, but a frequency between 0.1 and 1 hertz. And the responses we get depends on the depend how fast you or how slow you're stimulating. So if you go faster, 0.1, 0.1 or 0.2, your responses will be smaller in amplitude. So if you look at this picture on the right side, so there's a single stimulation, 1 hertz stimulation, and the second picture is non-depolarizing block, and the third one is depolarizing blocks. So the non-depolarizing block, they are slower in action but the longer effect. So the single twitch remain there for a few minutes, and then they start decreasing amplitude and they disappear. Compared to the depolarizing block, it's an immediate effect. So the succinylcholine, but it recovered within 5 to 6 minutes. So the second one is tetanic stimulation. So tetany is a continuous stimulation, and it's a monophasic square pulse. Duration is 0.5 millisecond, and it's repeated at high frequency stimulation, usually 50 hertz stimulation. Typically, it can be done between 30 to 100 hertz, but 50 hertz is the most common one. And we can see fade with non-depolarizing use. And if the inhalation agent are used, they augment the fade. We can also see the post-tetanic facilitation. So the first picture on the left side, you look at the first picture on the left side. So the first picture on the left side, we have stimulation. This is a 50 hertz stimulation. So the black is the box is a 50 hertz stimulation. That means the distance between every stimulation is 20 millisecond. It's a continuous stimulation. So the second picture, if you look at the responses, the control, we have there's a single twitch, and followed by a block of this white block of 50 hertz stimulation, and there's no effect on the responses afterward. So after given this control, we have a moderate non-depolarizing block, and if you look at the response, you have a single twitch, and when you run the 50 hertz tetanic stimulation, you can see the fade. So there's a fade, so that means the responses, the first and last response, they are decreased, they have a different amplitude. And if you stimulate after that, it's called post-tetanic facilitation. That means the responses are much higher. So the amplitude is more than twice, 3 times, or almost 4 times, and then it decreases. And that's a sign of using a non-depolarizing block. And if you the last picture is the control for control with the 50 hertz tetanic stimulation, and with the use of the depolarizing block. So there's a same amplitude response followed by a stimulation, and there's no response. If you're stimulating, we are not getting anything, and this patient has paralysis for a few minutes, and after that, when we stimulate again, we have same amplitude response. So there's no fade while we're stimulating, and there's no post-tetanic facilitation. So that's about the just very brief overview. So I just wanted you guys to know that 3 types of stimulation, and one of them is single stimulation. The second one is tetanic, and the third one now we are going to talk about is the train of force stimulation. So it's the most common stimulation, and the setup is 200 milliseconds. The frequency should be 2 hertz, and it doesn't require baseline. And every stimulation you can get the information. So we compare the fourth twitch to the twitch number 1, and we do train of T4 to T1 ratio, in that increase the fade. So the T to 4 ratio is 101, there's no fade. Or if the ratio is decreases with every, we get the fade. So the decrement in twitch intensity and seam amplitude is called the fade. So the fade is the decrease in the amplitude of the second or third or fourth response. So the train of 4 test is based on stimulation of peripheral nerve resulting in 4 twitches. The first twitch is known as T1, second is T2, third is T3, and 4 is T4. And the calculation of percentage of CMAP is decreased from T1 to T4. T0 is also a baseline twitch, but T0 is only used when we are doing a single twitch stimulation. So train of force stimulation, if you have 3 after 4 twitches, you lose the fourth twitch. That means you have only 3 by 4. So that is 75 to 80% block. So losing one twitch means that we lost more than about 75 to 80% patient. If you have 2 by 4, the T3 is gone, 85% muscle are paralyzed. If you have T2, then which is 1 by 4, 95% muscle are paralyzed. And if you have T1, is also gone, 100% block, so that's 0 twitch and 100% are paralyzed. So even in presence of T4, there's a 5% paralysis because anesthetic inhalation agent have some paralysis effect. So if you look at this diagram, so it's impossible to it's not possible to do accurately monitor if you have a train of 2 by 4 because you are monitoring 15% twitches. And the other important thing is when we do MEP, so all the data says that when we stimulate corticals, we do cortical stimulation for motor evoked potential, we recruit only 5 to 10% of the corticospinal tract. So we are recruiting only 5 to 10% of fibers. We cannot recruit more than that due to anatomy. And if they have 80%, 90% muscles are paralyzed, then you are not monitoring like less than 2% of muscles and giving the wrong information to the surgeon and to the patient. So the single twitch is a single twitch, train of 4 is the middle. So we use the same single twitch. We stimulate 4 times with the 52 hertz stimulation. And if you see the right side, you can see the fade. And if you see the fade, that means we are using deep non-depolarized muscle relaxation. So non-depolarizer, they cause the fade and exhibit the fade again. And fade may progress to no twitches if enough muscle relaxant is given. You can see either first response at maximum, the second is smaller, the third is smaller, and the fourth smaller, or you see first, second, third, and you don't see the fourth one, or you don't see only one response, or you don't see nothing at all. So those are all possibility. And so next time you go to the OR and you lose a train of 4 and you have a fade in the head, so you will know that this is because of a non-depolarizer, not because of succinylcholine. Succinylcholine does not cause the fade unless it's go to this very high dose. So train up for response, again, the first one is T1, T2, or also known as response number 1, R1, R2, R3, R4. So the objective of doing the train of 4 is to a post-operative muscle relaxant occur. Even the intermediate acting drugs are given. So now all the research is going to do EARP, which is enhanced anesthetic recovery, and everyone is trying to, the anesthesia, they are focusing on enhanced recovery, so the patient recover quickly and they don't stay intubated for a very long time. In order to have enhanced recovery and a quick recovery, they have to have a dead diaphragm. Muscles have 4x4 twitches, so trainer 4 can help in a great way, giving them a feedback. They can extubate the patient because there's a risk. There are published literature with there's a risk of post-operative pulmonary embolism and post-operative uh, problems because the patient was not fully recovered in the OR and was extubated. So, and also it's very important that if the twitch number 4 or the next twitch is not more than 0.9%, that means the neuromuscular blockage is not fully recovered. So for recovery, we use the ratio of 0.9, we don't use the 0.4. And intraoperative trainer 4 monitoring is needed for the appropriate muscles to make sure the EMG monitor is reliable. So those are the reasons we do that. So every time you're doing EMG, muscle relaxation, MEP, our goal is to have no muscle relaxation while we are monitoring. So the pattern of the trainer 4, so I have this picture just to give you everyone the difference between the depolarizing and non-depolarizing. So the first picture, it is, you can see non-depolarizing neuromuscular blockage was given, and you can see the fade, and it lasts for a very long time. And neostig mean, which is a reversal muscle relaxants, and neostig was given, and it causes reversal and full amplitude. So succinylcholine, which is a depolarizing agent, and in number B. So when succinyl is given, there's an immediate drop, but there's no, not fade, it's a drop, and then it's a quick recovery. If you look at this, and the first picture number A and B, they are single twitch stimulation. Figure number C is a trainer 4 stimulation. So if you give a non-depolarizing agent, you can see trainer 4, you have all good amplitude, and after a few minutes you'll see the fade in. You see the fade, and then you see the fourth twitch disappear, and that second disappear, and the first disappear, and nothing. And if you give a new stigmine or it recovers, you see a post-tetanic facilitation because the first twitch is bigger and it's bigger than the previous one. Compared to succinylcholine, you'll see when you give the succinylcholine, you'd see the trainer 4, all 4 twitches will decrease in amplitude. You don't see the fade in each amplitude. So that's a classic difference between non-depolarizing and depolarizing trainer 4. So if you're doing a programming setup, so all the pictures I've put because we are moving to new platform very soon, and it's Surgical Studio. So instead of putting it, so I just put the picture. So if you open the new Surgical Studio, once we start doing that, so we are not doing it right now, we're just doing the testing. So you open, the window will look like that, and you will have electrodes on the left side, and then you have montages on the right side. So how to write that program? So just starting off, just a simple trainer 4 program. If you open any new program file, and you'll see a blank screen, and there'll be nothing there. So what you have to do is pick up an amplifier. So you have 4 amplifiers. It's a 32 channel machine. You have amplifier 1, 2, 3, 4. 1 and 2 are pod 1 and 2. They are amplifier 1, and pod 3 and 4 they are pod amplifier 2. We don't recommend referencing the electrode from one amplifier to other one. You can reference the one part to another. They are same amplifier, but from one amplifier to other is not recommended. So if you're writing a program or adding a trainer 4 in Surgical Studio, so you don't have to type it. So most of the muscle they are entered. So if you search for the muscle, just type left abductor helices. You'll see. I type left abductor, so all the options of left abductors are, and you can see their arm, leg muscles, or left side or right side. and then you can select that muscle, and you enter one muscle, it will appear as active and reference, so you don't have to type it twice. So you do left side and right side. Once we have populated those in the amplifier, then you can go to the right side, which is the amplifier, and you click in 1 and 2, you'll get a channel 1. In amplifier 2, you get the first channel, which is the left foot, and 5 and 6 will get a second channel. And the gain, typically 500 to 1000 is no more than enough. And the high cut should be set for 5000 hertz, and low cut should be set to 10 hertz for all your trainer 4, and also for EMG activity. So the next step is the first left corner is channel setup. So this is the first. And then we move to the mode setup. So you click on the mode, and then you get this icon plus sign. And if you click on this icon, you get a window, and you can select you want to add a left upper SSCP or right lower SSCP. And if you click on left SSCP, it will show left, median, right. But I'm not going to talk about that. So you just click on trainer 4. It on the right mode, it will show TOF, and then we say OK, and the last one is save. So it will, once we do that, you select the trainer 4, a window, a mode of trainer 4 will appear. And then you can, on the left side, we have amplifier boxes. So you can select left or right side. So just click on left side, it will show that left abductor hollis and channel 1. And you can create peaks, label peak and trough, and you can create the midpoint at what is the latency of peak 1 and peak 2. On the right side, we have the left stimulator setup. So if you have EX9, if you have one EX9, it will be stimulator 1. If you have two EX9, you will have stimulator 2. So if most of us, we are using 1 right now, so it will be stimulation 1. And if your left tibial is in 3, you'll have 3 high. And then we have constant current stimulation, and the pulse rate is set to 200 microsecond. The intensity starting, you can start from less than 10, but if the patient is light or awake, but 15, and maximum it can go to 100, which I don't like to go. And the polarity is set to reverse because the first picture I show you, we are using the cathode proximal and anode distal for SSCP, and we use the same stimulator for trainer 4. So we reverse the polarity, so the distal becomes cathode and the proximal become. And the last one on the list is 2 hertz. So this is the whole setup. And then we click save. It will save a mode. And then we can click, the third one is test. So we create the test, and test, you can check you can create multiple tests. You can have maximum of 16 channel in each test. So you can have 10 tests and you can make 160 channels. You can have 20 tests, you can have 320 channels, but you cannot have more than 16 channels in one test. So you're doing more than 16, you need to split into different tests. So I just selected left and right trainer 4. So, and once you we go to the view, and again, you have an empty view, and you click on the plus to add a new window. Once you act, it will show you want to add a left trainer 4, right trainer 4, chat window, event log, everything. So you can select all of them which you want to enter, and then click save. It will create that window. And now we have it's the drag and drop function is much easier. So you can, there's a small cross in the middle, and wherever you want to put this window, that it appears a highlighted light blue. So this is left, right trainer 4 and left trainer 4, and then save. Now we have a test with a trainer 4, left foot and the right foot. And if you want to change the view, you can click on this pencil edit. You can rename the view trainer 4 or something, and then save it. So all the tests, all the windows, you don't have to go to the test. So you can just click on this cursor, this is a circle. You click it and the windows appear. So you can run horizontal, and you want to change a vertical view, you can histograms, you can change the view, and display gain and sweep. The sweep should be 20 millisecond. So this is one common thing I see all the time. Most people, they have set up for 2 to 3 millisecond, 2, 3, 4, and all the waves are overlapping. The latency of trainer 4 is about 8 to 10 millisecond. So if you want to see the first twitch and second twitch separately, you need to make sure it is set 20 millisecond per division. So depending on which nerve we are monitoring, so again, if you're monitoring the distal muscle, we need to have trainer from the foot. If you're not monitoring foot, you're just monitoring hand muscle for any reason, then you can do median nerve or ulnar nerve as trainer 4. And if it's just craniotomy, for some reason, you're not monitoring any lower extremity muscle, you can do facial nerve. So for posterior tibial nerve, we stimulate the posterior record for abductor helices. Peroneal nerve stimulation has to be done at the knee, and the recording is tibialis anterior, and the median ulnar at the wrist, and facial nerve. So the setup again is monophasic square pulse, and the duration is 0.2 millisecond. Stimulation rate is 2 hertz, pulses for 200 milliseconds, sensitivity 2000. So everything is 2, so you have 200 microsecond pulse, 2 hertz for 2 seconds, 200 microsecond sweep, and 200 microvolt sensitivity. So that's your trainer 4 setup. So for lower extremity, we can do posterior and peroneal. The upper, we do a median ulnar. Face, we can do facial nerve. So if you're doing a trainer 4 from hand, median nerve stimulation is a typical median. You go between the tendons of palmaris longus and flexor carpi ulnaris. And ulnar nerve, you go more medially. So again, the cathode is proximal, anode is distal, but it is set up for the ulnar nerve SSCP and median nerve SSCP. But if you're doing trainer 4, you have to reverse the polarity. So the negative becomes the distal and positive become proximal. For posterior tibial nerve, the tibial nerve, the anode should be behind the ankle. For trainer 4, for SSB should be, this will be the same, and the positive or anode is distal, and reversing the polarity will make change. Peroneal nerve is the tricky one, because peroneal nerve is the sciatic nerve come behind the knee, and it splits into peroneal nerve and common peroneal nerve and posterior tibial nerve, and common peroneal becomes superficial and deep peroneal, and tibial nerve is again split into uh, uh, 2 branches. So peroneal nerve turns around behind the fibular head. So you have to palpate the fibular head and put the cathode or anode and stimulate. So if you have, again, this is for SSCP, but if you're MEP, then for trainer 4, the negative should be distal. And you cannot palpate this unless patient is very, very emaciated or very, very thin. So you have to bend it, because it disappears when the leg is extended, it disappears behind the fibular head. So you have to stimulate, feel that you have to bend the knee and feel the head of fibula, which is behind the head of tibia. If you put the electrode on the head of tibia, you're not going to get any trainer 4. Facial, again, you can put the electrode in front of the ear and have negative and positive and do trainer 4 and stimulation and the recording from the orbicularis oris. Same muscle setup, foot muscle, tibialis anterior, and hand muscle and oculi. So the abductor helices, the foot muscles, it's under the big toe. So if you want to record from abductor helices, you have to put the electrode here. If you want to record from extensor helicis brevis, you have to go feel between the first and second metatarsal. So many times people, they put the electrode very distal, and the distal behind the toes, and you don't have any muscle, they're all tendons. So you have to make sure you put the electrode where the arrow is. You're very proximal, you're not distal. Tibialis anterior, again, is very right on the tibia. If you go 1 centimeter more lateral, you will be on peroneus longus muscle. Abductor digemini and extensor pollicis brevis or abductor pollicis brevis for the ulnar and median nerve. So the electrode we are going to use, we use the subdermal needle electrode for recording. We use subsurface electrode for stimulation, and then we need to have a ground pad. The ground pad is the best one with a square, big 2 to 3 centimeter. Uh, uh, the needle ground, they are very poor ground. They produce a lot of artifact. 60 hertz noise, and they have stimulation artifacts. So if you want to get if you have issues with your stimulation artifact, start using the ground electrode, which make your life much easier. So if you look at trainer 4 on different platform, it will show on the different, very, very different. So the first one is on the left side, it is Surgical Studio. The middle one is a Classics. At the right side is Medtronic. So on Medtronic, it is stacked on 1, 2, 3, 4 on top of each other. So this is the patient. So I just want to show you some data and see what is your feedbacks. So this is a patient, number 1. We're stimulating a train of 4 at 25 milliampere, and the amplitude of responses is very, very small. So what I did, we increase the stimulation to 30 milliampere, and now the responses are a little bit bigger, but they are still not very, very good. So we increase the stimulation to 40 milliampere. So we have responses present in all, and there's some type, I don't know why the third one is not, but all the responses are present and they're all same amplitude. There's no fade. Increase the stimulation to 50 milliampere. The signal is getting bigger and bigger amplitude. And you go to 100 milliampere, now you have multi-phasic and very huge response. Same patient, same responses, different threshold. So but where the question I ask from all of you is, which one will count as train of 4? You'll count the train of 4 at 100 milliampere, you count for 50 milliampere or 40 milliampere or 30 milliampere, or how high you will go, and does it matter to go higher and interpret as that? So this is patient number 2. The response is at 25 milliampere. We are stimulating at 25 milliampere, and we're getting so you increase the stimulation to 30 milliampere. So do you want to stop here, or you want to go to the next level, or is it enough to go to train of 4, or you increase higher? So if you go to 30 milliampere, you get a huge response. If you increase 35 milliampere, same patient, the response are clipping off with the same sensitivity. 50 milliampere, so the sensitivity I have decreased to 500 microvolt, but so this is huge response. And at 75 milliampere, they are clipped off, and the sensitivity is, instead of 50 microvolt, it is 500 microvolt. And 100 milliampere with the gain of 500, they are clipped off. You don't see any response. So now the question is arise. So if you keep going up and up, you'll get a response at the end. But does it mean that the patient has full 4 twitches at 30, 35, 50, 75, or 100? So another patient, the patient number 3. So we have this patient have trainer 4 stimulated at 8 milliampere at 45 milliampere. The stimulation is fixed to 45 milliampere, 8:11 a.m. And you can see fade with, so that means it's giving a non-depolarizing muscle relaxant. On the right side, at 10 o'clock, after 2 hours, the same patient at 45 milliampere, it has very nice 100% increase in amplitude, all 4 signals at the same time, at the same amplitude. But are you going to decrease the stimulation, or are you going to keep it 45 milliampere, or you want to 40 milliampere? Does it matter or not? Another patient, the stimulation at a 100 milliampere, so it's a maximum stimulation and have no twitches at all. So this is on Medtronic machine. So 100 milliampere, after some time, we get a response, only 1 twitch, and there's no response. And the stimulation is set to 100, and later, after we are getting the second twitch. The first twitch is getting bigger, and the second twitch is 2. Also, later, same as we get 4 twitches. So we are getting 4 twitches at 100 milliampere and nothing below 100 milliampere. So are you going to consider this as a trend of 4 present, or are you going to say there's something, at least 50%, 60% of some muscle are paralyzed? Because if you stimulate the nerve directly, you get a response at 1, 2, or maximum 3 milliampere. And if you stimulate through skin, you should get response less than 10 milliampere or 5 or 6 milliampere. If you try to stimulate yourself, you can start feeling within 4 or 5 milliampere, and after 10 milliampere, you start getting cut off. So again, this one, if you have a trainer 4 running at the same time and you see the EMG also, you stimulate trainer 4, you can see the twitches, and you know the stimulation is working. You're getting evenly spread out, and which muscle you're stimulating. So it's always good to have a spontaneous EMG running at the same time when you're running trainer 4. Another patient. So I'm starting from 35 milliampere because I was not getting any response below 35 milliampere. So 35 milliampere was the first response at the top at 8:42 a.m. And I increased the stimulation to 44, got bigger, 54, get bigger. Every 10 milliampere, the response is getting bigger, and 75, 85, 95, and 100. So after almost 75 milliampere, it peaked out and it did not increase in amplitude. And there's no fade also. There's no fade. All the signals are at the same amplitude. But if you have something like that, where you are going to select, you have 4 twitches. So does it matter to have 4 twitches at 75 or 44 or 34? So another patient, stack, we're looking for same 35, 44, 54, 75, 85. So nothing below 35 milliampere, and you start increasing, you see no fade, but the amplitude getting bigger and bigger, and at 65 milliampere, it peaked out. Another patient, so stimulating at 24 milliampere, the first response appeared at 24 milliampere, and then increased to 30 milliampere, 35, 39. So 39 was the reliable response, and 44, and it was getting better and better, and it peaked out about 40, 50 milliampere. And after 100 milliampere, then I decreased to 24, it just dropped. So now the interpretation is very, very crucial for these cases, because if you are using 25, 35, 45, 55, it changes everything. If we stimulate the muscles and get a response at a threshold, and if you're supposed to get less than 5 milliampere and you stimulate at 15 or 20, then that means there is muscle paralyzed. And if you have to stimulate at 50 or 60 to get a same response you can get at 5 milliampere or 6 milliampere, that means they're muscle paralyzed. So you cannot say 100% muscle or you have trainer 4. You get the same response at 90 or 100 milliampere. A lot of people, they just go uh, to the maximum. So the super maximum stimulation is a confusing terminology. Super maximum stimulation is typically used, you go to threshold. When you get a threshold, you go twice, you go higher than threshold. When it peaks out and higher than that is a super maximum. Super maximum doesn't mean that you go to the maximum possible on the machine. Super maximum means that you stimulate at the maximum where there's no increase in the amplitude after that. But if your super maximum is 25 and in one patient and it is 75 in other patient, that means the patient has 75 milliampere. Trainer 4 has a muscle paralyzed. Another same trainer 4 response is increasing the stimulation from 35 to 54, 55 to 50, 45, and then decreasing again. It goes up and up. So having a clear plan is the most important part of trainer doing any type of monitoring. Communication of anesthesia team is the crucial before the surgery starts. So you know they are doing a short acting or long acting muscle relaxant, or talking to the surgeon, making sure he knows that if you need any muscle relaxant for exposure part or something, and what will be effect on our signal. So I'm just going to list some of the factors which most of us we don't look at it, and they affect your trainer 4. Calcium channel blocker, if the patient is on beta blocker, calcium channel blocker, mostly giving for hypertensive, anti-hypertensive medicine. you will have effect on trainer 4 depending on the dose. If patient is on corticosteroid, it will affect your trainer 4 and EMG and MEP responses. The patient is diuretic, such as furosemide or thiazide, taking anything, oral or IV, patient you will affect on SSB and MEP. Why? Because it will cause hypokalemia, hyponatremia, and it will affect the signal. If the patient has carbamazepine, it will affect your SSB. If the patient's inhalation agent will affect your some type of paralysis. Antibiotics also have effect. Clindamycin, gentamicin, kanamycin, neomycin, streptomycin, like a lot of antibiotics, they have interference with the neuromuscular junction and they affect the signal. So that's why one of the reasons we on the in the QA and all this is we stress on going and checking the patient history. So all these medications, if these have the, and if you don't have the good MEP or EMG or trigger EMG responses, then you know something is going on. Antiarrhythmic drugs, hypokalemia, hypocalcemia, hypomagnesemia, all the electrolyte imbalances, or patient has renal or hepatic failure, or myasthenia, or especially neuromuscular diseases, you'll have some changes. So the purpose of my talk was to make you think and go back and try that in the OR and see, look at the patient history, what drugs they're taking, what pathology they have. This is a picture you have for, like this one picture I'm showing is 45 milliampere. We have a fade with non-depolarizing drug. So are you going to consider it as train of 4 or train 1/4? Or are you going to go higher? Or you're going to stop this or tell the surgeon, Anesthesia, I have only one twitch and I will wait until the testing, or you're going to keep going higher until you get a solution. So why we need to do train of 4 the correct way? Because the interpretation of the responses to avoid false negative result. It can have bad effects. So particular stimulation threshold, they all depend on your trainer 4. Peripheral nerve stimulation, you're doing tethered cord or drazotomy or any type of peripheral nerve tumors. Cranial nerve stimulation, you're doing CPA tumor, microvascular decompression, and motor evoked potential, cortical mapping, rhizotomy, XLIF, DUNEV, all these. So all these factors, the one we listed, and all the drugs, all the pathologies, all the agent they interfere your trainer 4. They will interfere your EMG. They will interfere with your trigger EMG, and they will interfere your MEP. So in conclusion, always set up most distal muscle, never set up proximal muscle. Uh, make sure your stimulation and recording setup is correct. You have, so even the protocol is all set up. All when you start stimulating, make sure the pulse rate is 200 microseconds. The rep rate is 202 hertz. It's not 2.79, 3.79, something else. It has to, because when you stimulation at 2 hertz compared to 3 hertz or 2.5 hertz, you cannot compare with the data, published data. So now that you're giving either less time for muscle to recover, or you're getting too much time to recover. If you're not getting trainer for one side, try the contralateral side. If you're not getting contralateral side, try the other limb. You're not getting, so at least you will know your muscle is working, your setup is working. And trainer 4 should be done throughout the surgical procedure. Even the muscle relaxation is not given many times. Most of the people, they argue that no muscle relaxation was given, and so why I need to do trainer 4, because the all the list I have, patient can have a different blood disorder with pathology. Because of the bleeding, patient can have hypocalcemia, it can have hypokalemia, it can have hyponatremia. During the surgery, can have blood loss, can have blood, and they can give different drugs which are not muscle relaxant, but gentamicin, neomycin, something. Patient have a tachycardia, they can give the patient a calcium channel blocker or something. So that will affect your MEP. So suddenly you start seeing all the variation and it's okay, I lost my MEP. And the surgeon say, I've not done nothing. So those are all the differences. So that's why trainer 4 doing continuous is important. And try to keep the intensity of minimum, but above the threshold. And if the threshold is very high, then you have to inform the anesthesia and know. So again, comparing the two pictures, one patient have 25 milliampere on the left side, the patient have 75 milliampere. If you're comparing those two, are these two both trainer 4? Does it matter to do trainer 4 and 25 versus 75 or not? Okay, thank you. So if anyone has any questions, I can answer. Okay, thank you everyone. If no questions, and if you can always call me, email me, or text me, and I will be happy to give you the answer. Have a good night.